We'll be looking quickly at the tibiofibular joints, anatomy, biomechanics, and the assessment protocol for it. You've done this, I think, in M4, and it doesn't hurt to review it again, as this does take a bit of a beating sometimes with these remote etiologies. So, off we go. Okay, here's the tib-fib in all of its glory, front and back views. The first thing to note is how thick the posterior ligament is on the inferior joint. The inferior joint is the most stable of the two. This is exactly analogous to the subtalar joint and also the radial ulnar joint. The inferior joint acts as a pivot point. This one does not do a lot of swing. Stuff pivots around it. It's a superior joint where the gliding is really occurring. And the gliding at the superior joint is anterolateral, posteromedial, with posteromedial gliding having the most resistance. So this moves towards its close packed position almost certainly. It's not exactly analogous because the fibula doesn't take part in the knee as the ulnar and radius do in the elbow. So it's not quite analogous, but it's closer and it's a much simpler joint for all that. So you can see the ligaments, as I say, the posterior and the interosseous ligament of the inferior joint they're the strongest ligaments. The ventral ligament is a little less strong than the two posteriors. Superiorly, the anterior ligament is the weaker of the two, while the posterior ligament is thicker. And of course, you have the interosseous membrane holding everything together. The membrane allows it to twist. It also allows the fibula to ride up a bit, which we'll see in a moment is really quite important for its biomechanics. So this is a bicondylar joint. The superior surface of the fibula is concave to the convexity of the tibia. Below it reverts itself, so the fibula is convex to the tibia's concavity. So this gives you basically a concavo-convex surface, which actually functionally makes this joint, when they're working together, which they have to, a modified sellar joint with 1 degree of freedom, which is pronation and supination. The close pack position is almost certainly pronation. When the foot flattens out and you're stepping over the foot, the ankle is fully dorsiflexed, and both the inferior and the superior joints become as stable as they're going to be. Now this also occurs with medial rotations. If I'm twisting, say, to the left, both the fibula and the tibia are moving into medial rotation, but the tibia moves more than the fibula does, so the tibia is medially rotating compared to the fibula, and basically this also produces pronation and close packing. So relatively simple joint, but it does take a bit of a beating with some of these remote etiologies. So these pictures depict what happens when you step over your foot in gait. It's the same thing that happens actually when you're twisting, which we'll look at in a second. But it's on that stance phase when you're coming over the foot and the ankle close packs onto the talus. So what happens is the talus, which is wedge-shaped and it's narrow posteriorly and anteriorly, the mortise glides forwards on the talus with that walking movement. So in order to accommodate the talus, the inferior tib-fib joint has to gap a little bit, so you get abduction of the fibula, and at the same time the fibula is thrust upwards against the tibial condyle, and that causes it to glide posteriorly, while the inferior joint glides very little bit anteriorly. As I say, the big movement occurs at the superior joint. The inferior joint really just acts as a pivot point, but this is twisting. The fibula is twisting on the tibia, but the movement is mostly generated by the tibia because this is where your weight is going. I think the fibula takes maybe 1/5 of your body weight on a good day, so 80% of your body weight is going through the tibia, so the tibia is the thing that's being driven most. So this is where the movement occurs, but the upshot is that these two bones twist around each other and basically pronate. When I come up onto my toes, then the talus moves forwards, and and we get the fibula returning back into a more adapted position. It glides downwards and the superior joint glides forwards. So this is almost passive recoil back to that position. Although when you're fully on your toes, there is some pull on the ligaments and the muscles attaching to the fibula and running under the foot to actually bring it back down again. The two diagrams on the left look at what happens during medial rotation. So you're standing now and you're basically twisting. This is the left tib fib. So let's say that you're twisting to the left in this particular picture. So sorry, you're twisting to the right. So as I twist to the right, the ankle dorsiflexes and both the tibia and the fibula medially rotate. Now the tibia is moving more than does the fibula because this is where it's being driven. So this will move medial in medial rotation compared to the fibula, which is relatively laterally rotated. So you'll see exactly the same thing happening when you was pronating and walking over your foot. That is, the talus has to come back. It basically abducts the fibula a little bit and drives it upwards, and you see exactly the same thing happen. This goes over the condyle, and then the head of the fibula glides posteromedially. When you twist in the other direction now, so now I'm twisting to the left. Essentially what you're doing is you're coming into an inverted position of the foot. If you go far enough, you'll roll over the side of the foot, but let's not do that. So as you roll to the left, the ankle plantar flexes, the fibula recovers. The tibia and fibula are both laterally rotated, but again, the tibia is doing more so than is the fibula. So we see exactly the same stuff happening now. The glide anterior at the top, posterior at the bottom, and a descent of the fibula back to its resting position. So you can test the movement of the tib-fib joints in two different ways, one with squatting and one with twisting. And they can be useful, as we'll see in the next slide. There are two reasons why you may be looking at the tib-fib joint. One is the patient's complaining of pain in one or both joints. And this will be a straightforward diagnosis based on the EIS or pattern recognition of whatever form of diagnostic procedure you're using. You make the diagnosis as a biomechanical dysfunction present. Then you carry on with the exam. The other reason you'll be looking at these joints is to see if they are indicators of a leg length discrepancy, or if they are contributing or causing problems within the unit, or more regionally. So if we're looking at these as a pain source, that is, this is your primary diagnosis, then we can be a little more direct about it and go in and grind each joint to make sure that joint is responsible for the patient's complaint. So if I go with this thing, compress them and grind them, both joints, and see if that reduces the patient's pain, then I'm happy that this is worth investigating. If I can't reproduce the patient's pain with this, then I need to be looking for something else. But let's assume that I do find that this is painful with the patient. I can't do PPMs here. I can't pronate and supinate the lower leg on itself. It's just really difficult to do, and you're not going to get very much from it at all, so you're better off doing this grinding. So there's no real PPM. So in this route, I'll come down, grind them, reproduce their pain. If this is positive, I'll then go and do the joint glides, which I'll come back to in a second. If this testing is negative, that is, I wasn't able to reproduce the joints, then it's almost certainly these are not the sources of pain. But just to make sure these joints are functioning okay, then I can come in and do stability testing. If the tests are positive, I have an instability. If they're negative, it's normal. But whether or not this is relevant to the patient is open to debate. Now, as I say, if these grinding tests are positive, I can then move in and do joint glides. If the joint glides are restricted, then I have a stable subluxation. If the joint glides are negative, then I've probably got an unstable subluxation, but I'm going to need more information before I can say that, and I'll come back to that in a second. So let's go from the etiological search perspective. So the screening test here is actually to feel the movement. So this replaces the passive physiological movement test with active movement. So what you're going to do is you're going to palpate the fibula, have the patient squat forward and go up on their toes, and you're going to feel for the fibula head to push up with squatting and come down with toe raising. And then you can twist them, palpate the tibia and the fibula both on both sides, and you feel the relative movement of the two bones. And see if they're moving normally. Now, if it's normal movement, it may be unstable or hypermobile. These active tests are not very good at picking that up, so I can come in and do stability testing. If they are positive, then I've got an instability. If they're negative, I may have a hypermobility, but if I do, it's not a painful one, and I can either make the assumption that this is normal or that it's hypermobile. And then wonder if it's causing other etiologies, other problems along the line. Now, as I said, the problem with not doing the active movement test is when you come along and basically you do the glides and the glides are negative. The reason why you can say when you do the active movement test that it could be a stable subluxation or an unstable subluxation is that the movement test showed that it was hypomobile. And so if they're hypomobile when you're weight bearing, but they're not hypomobile in non-weight bearing, then basically you're looking at an unstable subluxation. That is, it subluxes because of body weight and then reluxes when weight's taken off it. But you have to know that weight bearing is already messed up to be able to say, well, it's not messed up now. So that's what it is. So that's the value of doing the active movement test. But more often than not, what you'll find is that if you're looking at this is a biomechanical dysfunction and the patient's complaining of pain from these joints, your grind test will be positive. You'll be able to reproduce the pain, and generally speaking, the glides will be restricted or seriously hypermobile, and then you can do the stability test and tell you that the patient does have a real problem here. And just before we finish, answer these questions. If the superior joint is unstable but anociceptive, what might it cause and to what tissue might it happen to? If the superior joint is unstable and nociceptive, what may it cause and to what tissue? If the inferior joint is unstable but not nociceptive, what may it cause and to what tissue? List 5 differential diagnoses for lateral knee pain and list 5 differential diagnoses for anterior ankle pain. While you're doing the differential diagnosis, give some thought to how each one is different from the others. Just don't list them out almost out of the book. Think about how they're different from each other.